So let's continue on. Since we've talked about our background information about what diabetes is and nursing care for diabetic patients, let's continue on with complications of this disease process. So if we look at the complications, we can kind of break these down into short-term and long-term complications. So we'll start with the short-term, and the first one being hypoglycemia. So this is by definition just a blood sugar level below 60. Most resources will use 60 as kind of the guideline there. You also hear this referred to as insulin shock. So this could be that maybe there was too much insulin in the body at one time, maybe too much insulin was administered at one time, maybe the exercise pattern has been pretty irregular, or they were exercising at a time of that peak action of insulin, and then that caused a severe lowering of the blood sugar. Maybe not enough adequate food intake during the day, vomiting, diarrhea, of course, losing fluids and losing body fluids and sugar that way, and then consumption of too much alcohol. We previously mentioned that the alcohol mechanism there in the body can actually decrease blood sugar by blocking the production of glycogen in the liver, and it also can have effect of increasing the insulin secretion and production in the body as well. So those two factors combined is what can cause a lowering of the blood glucose level. And also just the physiological effects of childbirth on the body can cause some lowering of blood sugar levels as well. So for diabetic patients and their families, they really have to be familiar with the signs and symptoms of hypoglycemia. They need to know what that looks like so that they can recognize that at home and manage the issue. And then as far as you as a nurse in the hospital, you need to be aware of what the symptoms are so that you can recognize those in your patient and identify right away that you might need to check a blood sugar and see what their blood sugar is at. So what are the symptoms that we're looking for? Again, different guidelines have different specific blood sugar numbers that they go by. The ADA guideline, they actually say blood sugar less than 54 would be considered hypoglycemic, but in the hospital setting, at a blood sugar less than 70 is where we start becoming concerned because we don't want them to continue to drop below that point. So less than 70 and accompanied by these symptoms, I need to treat that low blood sugar. So what we're looking for here are these, kind of break it down in cardiovascular symptoms and then the CNS symptoms. And the reason that we see these symptoms is when glucose decreases in the body, there's an adrenergic response, and so that is caused by release of epinephrine, cortisol, and glucagon, as well as growth hormone in the body. So all those hormones get released, and that causes this adrenergic response, and so then we'll see the tachycardia, we'll see the palpitations, the anxiousness, restlessness, diaphoresis. And with the neurological symptoms, just think about the brain needs sugar to function. So without glucose or a low level of glucose, it can definitely affect their orientation and their mental status, and can see the lethargy, slurred speech, even progress to a state of coma. So always be very aware and alert for these symptoms when caring for a diabetic patient. And also remember that beta blockers can mask that adrenergic response. So if you have a patient who is diabetic and they're also on a beta blocker, be aware of that and that those symptoms might not be quite as evident. So treatment for hypoglycemia. Rapid treatment is mandatory. It is a must. We have to get their blood sugar levels back up so that we don't have any permanent brain damage or permanent effects. So we need to make sure that we act quickly and that we get some source of glucose on board for that patient. Kind of depends on the situation. Are they conscious? Are they alert? Or are they in a state of unconsciousness? That's going to decide what route of administration that you're going to use. So there's instant glucose, buccal or IV if unconscious. If the patient is still conscious and they're able to eat, swallow, drink, things like that, then some source of fast-acting sugar intake, PO, is okay. So there's glucose tabs. You could just give them like a 4 to 6 ounce cup of orange juice. sugar cubes, honey, corn syrup, a non-diet soda, anything like that. We just need to get a quick source of glucose on board, and then follow that up with a carbohydrate and protein snack of some sort to help maintain and stabilize the blood sugar so they don't drop. And then if the patient is unconscious though, then we need to, or have an impaired gag reflex, also something to consider. We need to be looking at a different route. So parenteral glucagon could be administered IM or sub-Q, and that can be given like either in the gluteal muscle, in the arm, or in the thigh. And the liver will convert the glucagon to glucose for then the cells to use in the body. So that could be appropriate, but I would say more times than not in the hospital setting, if you have a patient who's unconscious, they're not able to take a PO source of glucose, then we usually do IV route. So IV glucose through administration of dextrose 50% or D50 is what you'll hear nurses say. That's administered IV push, and so obviously an RN would need to administer that. But you're going to want to, whatever glucose source that is being used for the patient, you'll want to repeat that about every 15 to 30 minutes until their blood sugar level is above and maintains above 70. So once one source of glucose is administered, you need to recheck their blood sugar in about 15 minutes. If they're still below 70, then you repeat and give another dose. Here's a couple of pictures of what D50 looks like. So this is considered a full amp of D50. 1 amp is 50 milliliters of dextrose 50%. A lot of orders will state on the MAR, it will state to start with half an amp, so 25 milliliters of D50, then recheck a blood sugar in about 15 minutes and see if it's above 70, and if the blood sugar is still below 70, then you repeat the other half amp of D50, so you would give the last 25 mils. D50 does raise blood sugars very quickly, so usually there is a quick effect. Usually we do see elevation and an increase in the blood sugar, but you need to make sure that before you administer D50 that you check a blood sugar immediately before you administer that, so that you have real-time blood sugar reading, so you know exactly what the level was before you treat it, and then you can reevaluate after it's administered. Okay, now moving on to diabetic ketoacidosis. We've mentioned this just a little bit in the previous part 1 of the lecture. You'll also hear just someone say DKA, nurses will say DKA, but it is basically a state of insulin deficiency, primarily seen in type 1 diabetics, that insulin-dependent diabetic, where they lack the production of insulin in the body. Doesn't mean that, insulin-dependent isn't talking about what medications they're using to manage their disease. It's talking about, do they produce insulin or not. So in insulin-dependent diabetics, which are type 1, glucose is unable to enter the cells due to a lack of insulin. That causes a state of severe hyperglycemia, significantly elevated blood sugars. And the cells, even though there's all this sugar floating around in the blood, the cells are starved for sugar because it's not able to be transported into the cells without insulin. So because of that cell starvation, the body initiates gluconeogenesis by breaking down proteins and fats, which is abnormal metabolism. When fats and proteins are broken down in the body, that produces ketones, and ketones are acidic in nature. So this leads to a state of metabolic acidosis. They're going to have a severely low pH level. The excessive acid buildup caused by ketones is, by definition, ketoacidosis. This, if it's not treated and corrected, it can progress to a diabetic coma and death, ultimately. So how does this whole cycle of DKA occur in the body? So when there's no insulin, no glucose from food is being utilized by the body, so the liver produces more glucose to feed the body, but again, no insulin leads to glucose sitting in the bloodstream, and without glucose for energy, the body begins to break down fats and proteins. Ketones are the byproduct of this fat metabolism, and these ketones then build up in the bloodstream. Ketones and glucose are transferred into the urine. The body's trying to get rid of those. So the kidneys use water to empty the bloodstream of the excessive amounts of glucose and the ketones. When that happens, we get excessive water loss. So that's why we see that increased urination, and then that leads to water loss and then dehydration in the body. That further potentiates and worsens the ketoacidosis, and this whole vicious cycle just keeps repeating itself until intervention is performed to correct the issue. So the etiology behind it, maybe there was an increase in sugar intake or too little insulin administration. Steroids, well known to cause increase in blood sugar levels. Stress on the body also can significantly increase blood sugar levels. Things like surgery, trauma, emotional stress, infection, and that's really a big one with kids. If we're talking type 1 diabetes, a lot of times we're talking children, and they of course are exposed to infection all the time in school and everything. So that is a probably the number one culprit for why kids will go into DKA. And preventing it is just through really good tight blood glucose control. So the symptoms that you're going to see with DKA, early on, some just a little more vague, discrete symptoms, maybe some fatigue, headache, a little bit of anorexia, nothing too major. But then once they get to the point where the blood sugar levels are rising significantly and now we're getting ketones building up in the body, that's when we're really going to start seeing a lot of these more significant symptoms. So get really weak and lethargic, could be difficult to arouse. Abdominal pain, vomiting is very common as well. The blood sugar levels are significantly elevated. I mean, easily 300 up to 800, could be higher. Fruity odor of the breath and urine. That is due to the ketones. Those ketones produce that fruity odor. And so when they're breathing, this patient comes in and they're in this state and they have altered consciousness and you're assessing them, you will notice this fruity odor of the breath, and that is due to the ketone production. And then when you test the urine sample, it's going to be positive, large amounts of glucose and large amounts of ketones present in the urine. And then Kussmaul's respirations are described as rapid, deep respirations. And what the body's trying to do with that is blow off the acidity. So it's trying to compensate through these rapid, deep breaths, trying to blow off all that acidity because of the ketones. So Kussmaul's respiration is very common with DKA. And that's the hyperventilation to help compensate for the acidosis. Large amounts of urine output, that polyuria, because the body's trying to flush out all that sugar and all the ketones, so it's going to incorporate more water there and try to flush it out of the system, so the kidneys are trying to compensate for that metabolic acidosis. But then that potentiates the whole problem of dehydration, so they're losing too much fluid and now they are very dehydrated when they come in. Increased thirst, polydipsia, and then the metabolic acidosis on ABGs. If they were to draw ABGs on a person coming in with DKA, typically their pH is below 7.30. It is very acidic, and their serum bicarb is significantly decreased as well, usually below 18. And so those are definitely big red flags as well. So the main goals in treatment for DKA, we want to normalize the blood glucose level, we want to correct the dehydration, and correct any electrolyte imbalances in the acidosis. So insulin replacement is a must. Obviously, it's one of the highest priorities. We need to normalize the blood sugar level so that the body will stop producing the ketones. So at first, an insulin bolus can be administered, and then the patient will be put on a continuous administration, an IV drip of regular insulin. That is the only type of insulin that can be administered IV. So an insulin drip will be initiated, and with that, with insulin drips, not IV push, but just continuous IV route, you have to check blood sugars very frequently. Talking at least like every 15 minutes, every 30 minutes, somewhere in there. We have to frequently monitor that blood sugar level because we don't want to cause them to go the other end of the spectrum and lower them too fast, too quickly there. So insulin administration, and then fluid replacement. They definitely need IV fluids because they are severely dehydrated from the polyuria. Closely monitor their I's and O's. Sodium and potassium replacements. So with all the fluid loss, they could be low on these levels. And also think about with insulin administration, insulin causes potassium to shift into the cells. So once we start giving all this insulin to correct their blood sugar level, we can then see a secondary hypokalemia happen because of the shifting of potassium into the cells. So potassium replacements might be needed to help normalize their potassium level. Testing the urine for ketones, that is definitely something you'll be doing with this patient, sending down urine samples and seeing if they're positive for ketones, and then monitoring just vital signs, in general, looking for those signs of dehydration and, tachycardia, hypotension, closely monitoring those. All right, so now moving on to a condition that we see in type 2 diabetes called hyperosmolar, hyperglycemic, nonketotic syndrome. So you can hear in the name, this is a nonketotic, there's no ketones produced. This is, similar to the causes of DKA in type 1 diabetics. Okay, we're having a high state of blood sugar levels, and as you can see here, it could be 800 up to 2,000. It is significantly elevated. We do tend to see this more so in elderly populations, and unfortunately it sometimes can be missed at the start, at the initial diagnosis, because they're so neurologically altered. They have a decreased LOC. And if we're talking elderly population, someone may initially confuse this as a neurological event like a stroke, something like that. So initially it might get missed until they check a blood sugar level and realize how elevated it is. There is about a 15% mortality rate, so that is significant. But the big difference here between this and DKA is that there are no ketones formed, because we're talking type 2 diabetics, so they still have the capability of producing some insulin. And so the amount that they're still producing prevents the breakdown of fats and fatty acids. So we don't get that acidity that happens with DKA. But it is a state of severely elevated blood sugar. So the symptoms that this patient will exhibit: the increased blood sugar, significant, and it's going to cause osmotic diuresis. So obviously when that happens, they're going to have massive amounts of urine output to try to flush out all the sugar that's in the blood. And because of the massive polyuria, they're severely dehydrated. They lose large amounts of fluid. The other big red flag is the neurological changes, a decrease in LOC. That patient's going to become confused when normally they may be, oriented ×4 on normally. So the decreased LOC, the polyuria, and the dehydration are very pronounced and very, very profound with this condition. And you can see the hypotension and tachycardia because of the dehydration, increased thirst because of all the fluid loss, and excess sugar in the urine, glycosuria is what that's called. You can see that as well. The diagnosis is made off of the significantly elevated blood sugar level, but with the absence of ketones in the urine. There's no ketones present. And typically, again, this is going to be in a type 2 diabetic as well. Can be misdiagnosed, as I mentioned, as a neurological event, CVA, things like that, due to the decreased LOC. So we have to make sure that we're aware of the patient's medical history, and if they're a known type 2 diabetic and they come in with this decreased LOC, I need to check a blood sugar right away to rule out this condition. And we do find that mortality rate with this condition is higher than with DKA. Because they don't produce the ketones, there's no acidity in the body, you're not going to see those Kussmaul's respirations, because that is a compensation method for the acidotic state that the patient is in. So typically you're not going to see Kussmaul's respirations with this. So we're going to treat this by replacing IV fluids because of the massive amounts of fluid that they've lost. They are very dehydrated, so we need to replace that. Insulin drip IV, regular insulin, and then monitor vital signs, again looking for any tachycardia, hypotension, and correcting any electrolyte imbalances that may be present. So again, looking at sodium and potassium, sodium loss through all the fluid loss, potassium shifts with insulin administration. So closely monitoring those on a BMP and replacing as needed. All right, another condition that we can see with diabetic patients is Somogyi effect. This is a rebound hyperglycemia in the morning time. And what's happening with this is there's just a swing to a high blood glucose level from an extremely low level. And usually we see this occur after an untreated insulin reaction sometime during the night. And so hypoglycemia stimulates glucose to be released, and the body's stress response releases the epinephrine growth hormone and glucagon. That stimulates that process of gluconeogenesis. Glycogen is transferred into and made into glucose so that the body can use it for energy. And then that's what causes the rebound hyperglycemia in the morning time. So diabetic patients who, routinely in the morning are experiencing high glucose levels, along with maybe some other symptoms. Maybe they're reporting that they have a headache every morning when they wake up, or just have some nausea with kids, maybe enuresis, nightmares. That's something to think about with type 1 diabetics, but those are all red flags, and we may need to be testing their blood sugar level in the middle of the night or in those early morning hours, like somewhere between 2 to 4 a.m. We may need to do a blood sugar check and see is their blood sugar level low at that time. So what's indicative of Somogyi effect is if you do a blood sugar check between that 2 to 4 a.m. time and their blood sugar's below 60, so they're hypoglycemic, and then we check it again at 7 or 8 o'clock in the morning and they wake up and their blood sugar's greater than 180, there's that rebound effect where the body's trying to compensate for that, and so it releases more glucose to be used, and now they're hyperglycemic in the morning time. So how can we, adjust things to correct that? May need to adjust the evening snacks so that way a little bit later at night, or reducing insulin doses. And this is not done quickly. We want to kind of do this slowly over maybe 3 to 4 days, and just kind of transition to where it's a smaller dose maybe at bedtime, and maybe also having a bedtime snack to help prevent that hypoglycemic episode in the night. And then there's also dawn phenomenon, and this is again an early rise in blood glucose in the morning with no hypoglycemia during the night. Most likely this is associated with increase in growth hormone production and an increase in secretion of cortisol in the body, and that's because that's usually during early morning hours. And we just manage this by altering the timing and dosage of insulin. Again, may need to delay bedtime insulin dose until after 10, just a little bit later, so we can help normalize those early morning sugars. But again, want to be careful that we don't cause that Somogyi effect with the lowering of the blood sugar overnight. So now let's focus on more of these chronic complications, the long-term complications of diabetes. So these occur due to impaired circulation, and the damage that happens to the blood vessels in the body ultimately results in peripheral vascular disease, or PVD. And that damage is because of the collection of glucose in the cells and capillary membranes, causes changes to the small blood vessels, causes them to thicken over time, and that's going to decrease the transport of oxygen, nutrients, and waste through the vessels there. So that results in microvascular damage as well as macrovascular. But for the microvascular, we're talking about retinopathy, neuropathy, and nephropathy. Starting with retinopathy, damage to the retinal vessels within the eyes there. So small hemorrhages and aneurysms can form in the retina from the damage to the blood vessels. Increases the risk of retinal detachment over time. Hard lipid and protein exudates can also occur in the retina. Can cause damage to the nerve fibers and as well as macular damage or edema, so the macula in the eye, a highly vascular area, can also become damaged and edematous. Usually it's kind of some sudden vision changes as that damage has been occurring to the blood vessels over time, and then now they're suddenly having some vision changes. Might see things like floaters in their field of vision. As you can see here, there's just kind of some black spots where the damage to the blood vessels actually just totally impairs any vision in that area, so it kind of comes through as just a black spot, and can lead to blindness ultimately if the progression of it is not slowed. So we need to recommend to our diabetic patients that they get a yearly eye exam, so that way we can catch any early changes in their vision and catch those warning signs, so that way we can slow the progression of the retinopathy. For neuropathy, and PVD kind of goes along with that, goes hand in hand, again related to just poor glucose control. It causes ischemic lesions on nerves and chemical changes in the peripheral nerve cells. So with neuropathy, there's this pain or numbness feeling in the extremities, and that can impair the patient's ability to know when injury has occurred to the tissues. They don't feel it. And so then, as you can see here, then we can see a development of a diabetic ulcer in the foot. And because of their poor circulation, they're going to be a poor healer. So that wound, will take a very long time to heal or may never heal. And with that poor healing, because of the high glucose levels, they're a higher risk for infection to develop, and so can be very challenging to correct and treat diabetic ulcers in the periphery. Some other issues that are directly related to neuropathy can develop neurogenic bladder, sexual impotence, and have delayed gastric emptying, because it causes basically loss of the muscle tone of the stomach, causes it to dilate and loses muscle tone there. So it can delay gastric emptying. And then talking about the kidneys, the nephropathy that happens, basically just the damage to the blood vessels, the capillaries in the kidneys over time, just causes increased permeability, and so the kidneys begin to leak out red blood cells, albumin, and protein into the urine, and so they're going to demonstrate and exhibit persistent protein in the urine, red blood cells, hematuria, increased creatinine, BUN, and hypertension can ensue as well. Eventually, with uncontrolled diabetes, that can eventually lead to renal failure. So you'll see a decrease in the urine output, oliguria, and then to the point of where they have no urine output and urea. Diabetes is the most common cause of end-stage renal disease in the United States. Okay, so there's a significant correlation between the renal failure and diabetes, as well as hypertension. 10 to 20% of people with diabetes have some nephropathy, some level of nephropathy, and they say that type 1 diabetics, their risk is 12 times higher. So significant risk there, and so they really need to closely monitor and control blood sugar levels to decrease that risk. And the other risk here is the extra glucose in the urine serves as a place for bacteria to grow, so that increases the risk of infection there as well. Looking at the macrovascular damage, we're talking about cardiovascular disease. High blood sugar levels damage the endothelium of blood vessels, allowing lipids to be deposited, and this over time thickens the blood vessel wall, causing sluggish blood flow throughout the body. High triglyceride levels and just excess fats floating around occur due to impaired fat metabolism, and so these fat stores break down and triglycerides increase in the liver, and that increases what we call lipoproteins, and those will eventually deposit into arteries, causing atherosclerosis. And that's going to block arteries, and that increases the risk then of a MI or heart attack and a CVA. It's a 50% higher risk of MI or CVA in diabetic patients. That's very significant. So keys to preventing this risk, decreasing this risk: weight loss, exercise, and nutrition are absolutely key in preventing cardiovascular disease in diabetic patients. So overall, just prevention of chronic complications, really strict, tight glucose control, controlling blood pressure. As I've mentioned, there's a significantly increased risk of hypertension with diabetes. The ADA does recommend people with diabetes and hypertension to monitor their blood pressure at home regularly every day to make sure that they are well controlled, and if they're on an antihypertensive medication, to make sure that's being effective in managing and controlling their blood pressure. Maintain good hydration, don't want to have any state of dehydration going on. Keeping their cholesterol under control. Really would like to see total cholesterol less than 200, LDLs less than 70, HDLs greater than 50, and triglycerides less than 150. And if the person is also a smoker, really need to look into a smoking cessation program, because that's just going to further worsen the vascular issues and the PVD, that damage that's happening there with the disease. So we will end part 2 here, and then we'll pick up with part 3 next and finish up with insulin and oral hypoglycemic medications.